Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are streaming live from the Moses Lake Professional Pharmacy Podcast Studio, and we are excited to have Dr. Pouya Shafipouron on our show today. Dr. Shafipour, welcome to our podcast.
I thank you for having me. It's my pleasure.
So you've got an interesting story. You were going to be a plastic surgeon. You're down in Santa Monica. You're going to be a plastic surgeon, and you decided you wanted to instead be a family practice doctor to treat chronic disease.
Yes. So yeah, I had an interesting journey all through high school and undergraduate. I was fascinated with surgery, especially plastic surgery, the reconstructive aspects of it. And in medical school, I did a lot of research, neurosurgery, plastic surgery, and I've never thought about going into primary. But when I was in a plastic surgery residency program at UC Irvine, just down the street, and I noticed that I was more drawn to my post-op diabetic patients, chronic congestive heart failure patients, and managing them in the intensive care unit rather than trying to be on the surgery and doing the surgical stuff. And after doing that for a couple of years, I had a change of heart. I just noted that this wasn't my calling. This wasn't something that I was meant to do. So I left in medicine. Once you do your internship year, you're able to get your license to practice. So I left. I didn't know what I wanted to do. And I left and just started kind of moonlighting. I did some ERs. I did some community clinics, just general medicine. And that's how I found out that I was really interested in just more primary care, adult primary care. And also nutrition. This was at the early stages of nutrition in the mid 2000s, where there wasn't any obesity medicine. It's called bariatric medicine. So while I started my family practice residency, I also started going to conferences and educating myself in nutrition, supplements, bariatric medicine. So when I graduated from my family medicine residency, I also was able to get board certified in, back then it was called bariatric medicine. Now it's called obesity medicine. And I've loved it since leaving. Yes.
So, Janet, what questions do you have for Dr. Shafipour?
So you have train wrecks in your office. And it's, I mean, just from our perspective, we see so many people with just a ton of medication, like from the pharmaceutical side.
Yes.
From when we first started 30 odd years ago to where we are now, the amount of medications these people come in with is just amazing to me. So how do you approach that with them? Because obviously they probably don't need all of them.
Yes, and we have access to where our system is on Epic, which is probably one of the biggest electronic health records. So it pulls information also from all over the country, and so there's a lot of information cleanup. And the first visit with a patient, we usually try to book like a longer half an hour, 45-minute visit to just go over a patient's medical history, past tests to see why they're on medication, and if we can clean things up. Because also if patients are going to different doctors, they might be adding drugs without properly knowing, if they don't have access to the whole history or testing. So yeah, so the first visit is always challenging, especially for chronic older patients, to see what medicines they're on, and if we can kind of safely take those drugs away, or if there's a reason that people are on a medication or not.
So do you de-prescribe medications often?
Yes, absolutely. Yeah, sometimes people are on multiple different types of hypertensive medications, and especially once I guide them to lose weight or work on sleep, work on exercise, work on mental health, they start losing weight, then we start taking away diabetic medications, start taking away antihypertensives, diuretics. Yes, absolutely. Sometimes prostate medications.
So tell us about the weight, while we're on the subject of weight loss, discuss the hormone metabolism connection.
So, this is a very complex question. So we have these hormones, and all hormones are working in concert, from the main metabolic hormones, which are insulin, ghrelin, leptin, these GLP-1, GIP, as well as thyroid hormone, cortisol, female, male hormone, estrogen, progesterone, testosterone. These are all working in concert, and each of them kind of does one thing. Cortisol is the stress hormone, so we need it for acute stress. But if we're chronically stressed, then it causes insulin resistance and it causes abdominal fat. Or thyroid is a hormone that really, it's a little butterfly-shaped gland at the bottom of the neck, but it's kind of the engine of metabolism. Estrogen, same thing. That some people have excess estrogen, some people barely have estrogen, and if it's too high or too low, we see metabolic issues. Same thing with leptin, which is secreted from fatty cells. If the leptin level is too low, we see that people feel hungry. And the opposite of that is with ghrelin. So we take my job at the first visit is to look at the whole patient, look at their, if we have labs from before, look at the labs, look at their habits, look at their lifestyle, and then I go through a very detailed kind of 24-hour food intake to see what they're eating, what time of the day, how they're sleeping, when their exercise activity is, when they're taking the medications, if they're taking supplement, timing is also important, and then how they feel mentally, if they're stressed, if they have chronic pain, things like that. Then I order more up-to-date labs to look at hormones, look at fasting insulin, fasting blood sugar, A1C, looking for fatty liver, which is a huge issue right now, and it's hand in hand, directly linked with insulin resistance. And then we think, okay, can I adjust the sleep? Can I adjust mental health? Can I add in some meditation, mindfulness? Are there dietary ways that we can change? And I don't push any specific diet. If someone prefers to be vegetarian, vegan, then I write a diet with macronutrients that's more kind of addresses that. I personally am a fan of kind of lower carbohydrate Mediterranean diet, pescatarian, a little bit of ketogenic diet, as well as time restricted eating, shorter segment fasting, longer segment fasting mimicking. Then we start adding these things to see if we can help with weight. But obviously, drugs, if we need to add a drug or take away the drug, we do that at the same time as well.
So tell us a little bit about non-alcoholic fatty liver. You mentioned that already a little bit, but tell us about what causes that, and tell us how people are tested for it.
Yeah, so non-alcoholic fatty liver disease is on the rise. And before, what was more common, especially before this epidemic of obesity, was alcoholic fatty liver disease that eventually can cause fibrosis of the liver and cirrhosis. But with the rise in overweight, obesity, we're seeing a lot of the regular liver tissue is being switched with fatty tissue, and the longer we have that, the more that's becoming irreversible, and the tissue is becoming fibrotic, and then it eventually leads into cirrhosis of the liver, which is irreversible. And it's directly linked with abdominal weight, specifically with fructose. Fructose is the fruit carbohydrate, fruit sugar that raises the fatty liver more than glucose does. And so addressing it would be addressing the abdominal adiposity, the abdominal fat. And the diets that work really well for those are really low carb diets, as well as fasting. If we can put the body into a little bit of a ketogenic state, it really helps with reversing the fatty liver. How is it diagnosed? Diagnosis is not as easy because liver enzymes, the part of the metabolic panel, the ALT, AST, GGT, these are liver enzymes that might be high for someone that has fatty liver, but they also might be normal. Certain ethnicities are more common. We see this a lot in Asian, Indian, Middle Eastern, more than Caucasian or African background ethnicity, that they're more, usually Easterners are more prone to fatty liver at a smaller weight. Ultrasound of the liver, specifically FibroScan, specifically measures the fatty and gives us a staging system for it. Liver MRI also is another way, and liver biopsy in extreme cases if we're trying to see the stage or if someone has fibrosis or cirrhosis or not. But as a general rule, if someone is overweight or obese, even if the numbers are normal, we assume there's some type of a non-alcoholic liver disease. Now the term is no longer non-alcoholic, it's metabolic associated. So it's a MASH rather than NASH. And MAFLD, metabolic associated fatty liver disease, rather than non-alcoholic fatty liver disease. The new term that we use.
How will their lipids present when they have metabolic dysfunction like this? What will their lipids typically look like?
Typically, we see the triglycerides are high. And then if we do a more comprehensive lipid panel where we're looking at the size, ApoB and the small dense LDL particle numbers will be a little bit higher. But triglyceride directly goes high when someone has metabolic syndrome and non-alcoholic fatty liver disease. And when one of the things we see with weight loss, we see the triglyceride levels start dropping pretty rapidly, more than we see with like LDL and the lipoprotein.
And what about HDL? Will they typically have a low HDL?
They could, yeah. HDL could also be low, and HDL is one of those tricky things that some people just are blessed with high HDL levels. There's not a whole lot of ways to really significantly raise it. Exercise, meditation raises it more. Sometimes I've seen people that start eating more fat, and especially plant-based fats or fish oil, omegas, the HDL goes up. But yes, with someone that has really bad fatty liver disease and triglycerides are up, HDL is typically low, maybe for men 30s, 40s, women 40s, 50s, and we do see a little bit of a bump when they become when they start changing their diets. But I don't know if it's significant or not.
Janet, your question.
What the important is that the triglycerides to HDL ratio goes down. So we want that ratio as close to 1-on-1 or even lower as possible. So if someone has non-alcoholic fatty liver and triglycerides, let's say 400 and HDL is 40, so you know that you have a 4-to-1 ratio. But if they can get the HDL to the triglyceride to 100, then the ratio goes below 2, and that's great. That's perfect. Where we want from what I understand.
So there's kind of a myth, I think, that floats out there that people aren't willing to make lifestyle changes to achieve this. And maybe that's partly just because, you know, social media or what we've heard or what people share together. But people have to be really motivated, I think, to change, but I don't think it's impossible. So tell me how you handle the motivation with your clients, because I feel like that's something that's really important for you. I mean, how do you handle that?
I feel like for different age brackets, it's a little bit different. For younger people, vanity is a big motivation. So I usually, when I see a weight loss patient, the first question I ask is that if I had a magic wand, how much would you want to be? If I could just zap you into whatever weight. And then they say, oh, let's say if someone is, a female is 200, oh, I want to be 130. I'm like, okay, boom, you're 130. So what's next? Why 130? Why not 150? Why not stay at 200? And the first question, oh, I want to be healthier. I'm like, you look healthy, you know, you don't have a heart attack, you haven't had a heart attack, you're not on insulin. How would you not know unless you did blood work that you're not healthy? Because, you know, we do things in life to feel good and not to feel bad. So pain and pleasure. And for younger people, pain is not typical health pain. For older people, for diabetic that has to prick themselves, or if having arthritis and knee pain and back pain, or fear of cancer, fear of going on dialysis, that's how you can motivate them. But for younger people, it's challenging. And we see a lot of overweight and obesity in teenagers and up. So vanity, okay, if you lose weight, you're going to take care of yourself. Self-confidence will go up. People discriminate. If you're heavy, you get discriminated. So I try to have them kind of put those into word and say, your homework is tell me, and you don't have to tell me now, tell me the most top 3 reasons why, if you lose this 50 pounds, 100 pounds, what would change in your life, and try to be unreasonable, because being reasonable, you fail. We want to be unreasonable. We want to kind of start dreaming. I have them draw some type of either journaling or some type of a vision board or dream board. Okay, if I lose weight, I can go bungee jumping. I can go start running. I have less pain. Fatigue is a huge issue with most people. And if someone loses 50 pounds, that's 50 pounds less that they're carrying. So energy level obviously goes up. Everyone, first thing they blame is this poor little thyroid. Oh, I think my thyroid is not working well. And we check the thyroid. Your thyroid is fine, but you're 100 pounds overweight. So maybe, putting those things in perspective and have them start dreaming and thinking about it. And, I see people fairly regularly, because also they get motivated and then they go and they're like, oh, I don't want to do that. So I see them regularly and try to keep them accountable. I also use buddy system. If they have friends that can keep them accountable. Now with apps, you can do that to put things in perspective, because I tell people weight loss is easy, weight maintenance is tough. And we have people that lose weight, and then once they get to their goal weight, it just all goes down the door, because also body starts fighting as well after you lose a certain amount of weight and wants to push you back up. So yeah, it is challenging, but for younger people, it tends to be more looks, vanity, activities, travel. For elderly, more pain, and health reason, and having them write this, having them become aware of it themselves. And once they start losing a little bit of weight, like, oh my God, yeah, I feel better. I have less pain. My sleep is better. My mental health is better. I'm more self-confidence, things like that.
So we've talked quite a bit today about labs. If you could say what the most important lab is for metabolic function, what would you say that is?
For metabolic function, one lab only?
Yeah, I know. You got to narrow it down, right?
Fasting insulin, morning fasting insulin is a good one, because if it's more than 12, you have a little bit of insulin resistance. If it's usually, in the double digit, because for diabetes, you sometimes get these in the 40s, 50s, 100. But fasting insulin is a good one. An easy one that people can do at home would be just check your fasting glucose. You can also get A1C kits, and A1C is probably more accurate than fasting glucose, because if you had a poor night's sleep, fasting glucose might be high, and then we might see an A1C of 5.2. So glucose goes up and down a lot more than we see with A1C for most people. But between fasting insulin and A1C, I think that shows where you stand. And then if we want to do more, then we look at a lipid panel. If we want to get more comprehensive, we check apolipoprotein B, which is the inflammatory lipoprotein that's more causes plaque and heart disease and whatnot. Or we look at the protein particle numbers to see, do you have the bigger, fluffier ones or the smaller ones? Lipoprotein A, which is another separate inflammatory lipoprotein, we also look at to see if there's a familial aspect. And obviously metabolic panel to look at the electrolytes, kidney function, liver, to see if there's any hint of a fatty liver, possibly. And usually with fatty liver, we see the ALT higher than AST with the non-alcoholic type.
So what if somebody does have a high fasting insulin, what would be your first response to them? I know every
First,
patient's different, but in general.
yeah, first response would be cleaning up their diet. Cleaning up their diet to see if we can address it with diet. CGMs are a great way to also kind of keep people accountable, because and now these are over the counter, and for most people, unless people are a little bit obsessive or older people, CGMs are a great tool to see the impact of the food that you're having on your blood sugar within a short time period. For example, for me, I love fruits, and fruits just shoot my blood sugar up more than if I have something unhealthy like processed food. And so I have to watch fruits more than I have to watch white rice, which is a big part of a Persian diet. So it gives people a lot of insight to addressing that. And I usually write people kind of a lower carbohydrate Mediterranean diet, and for people that are open to it, add some time restriction in there, maybe some intermittent fasting, and start addressing it from there.
So what are your thoughts about, speaking of CGMs and continuous glucose monitors, what are your thoughts about people wearing them long term?
I don't know. I don't know if you're diabetic on insulin, they're a great tool. Long term, it depends on the person. So I have patients, especially elderly, that they get very obsessed about it, about the numbers. It interferes with their sleep because it beeps, wakes them up at night. So long term, I don't know. I'm not a big advocate of it. Unless someone is young, is not necessarily, it just they want to be on top of their health, or if someone is on insulin, or diabetic type 1s or type 2s that are on insulin, and they have to be because they kind of they either don't produce insulin, or their diabetes is too advanced. This is a great tool to make sure you're not going up and down, you're in the perfect range. But for a non-diabetic, or for a regular person, I don't know how much benefit it is to it.
There, as you know, I agree with you. As you know, there's just been a big, because they're so easily accessible, there's just a lot of health influencers that are recommending everybody, that's a strong word, but they recommend, lots of people wear a CGM continuously, just to see what their blood sugars are doing. And I personally, I've worn a CGM. I did it for a month, and I'm glad I did. But kind of like what you did, you saw that, fruit spikes your glucose. Okay.
Yes.
Then you need to be careful than eating fruit. I think the problem with people, and I'm talking mostly type 2 diabetics, wearing long-term CGMs, is then they end up chasing their blood sugars. They eat bad, and then they know it. So their glucose spikes, and they do whatever they have to do, inject more insulin. And it's almost like it justifies them eating bad because they know what's going to happen, and then they can react. And when in reality, I think we need to teach people long term. It's like, look, what happened over this period of time when you had your glucose checked for 24 hours or a month at a time. You know what happened when you wake up. You know what happens when you eat carbs before you go to bed, exercise. You know what happens. So I'm not a big fan of using continuous glucose monitors long term, especially for type 2 diabetics.
Yeah. But again, unless the A1C is really high. But if the A1C is becoming normal, yes. And what you're saying, I've seen patients do that they say, oh, better life. We had a doctor that did that, better life through chemistry. He would, I would take call with him some nights in the hospital, and he would eat the worst food at like 2 a.m. He would have pasta, thick Italian. He would buy it for the entire staff, and cake and stuff, and then he would take his meds, and he would say, well, better life through chemistry. I'm alive because of this and that. That type of a person, I don't know. It's their life, and especially this was a doctor. I respect that this is what they want, but to advocate that and talk about other people, I don't know. I don't know how much, especially as a healthcare provider, how beneficial that is, because we need to kind of set the example. But yeah, I use CGMs every once in a while when there's a new model. So, like Libre, for example, has a newer one that's now 15 days, and the old ones got influenced by vitamin C and citrus. So new ones didn't. So I tried it to see, okay, if I'm having vitamin C, if I eat a lot of salty stuff, or sour stuff, if it spikes it or not. And interestingly, it wasn't. One of the other things with CGMs is they're not the most accurate. So for a diabetic, when they use it, they have to still prick themselves every once in a while to calibrate it. Libre, you can't really calibrate, but Dexcom, you can calibrate it. And when I've worn Dexcom before, I've had to calibrate it a few times in the 10-day period that I wore it.
I think they're great tools, and I'm glad they're becoming less expensive and more accessible. Yes. And I will tell you, even from my standpoint, when I wore one for about a month, it was interesting to see what exercise did. Mm-hmm. During exercise, your glucose rises.
Mm-hmm. Yeah, you release glycogen. Yeah, absolutely.
Yeah, and so a lot of times, I kind of wanted to see what would happen during a bike race. I'm an endurance mountain bike racer, so I wanted to see what happened during a 5-hour race. And my glucose average was 140 during a race. And when I crashed,
your body was producing a lot.
When I crashed, it spiked to 170 twice. And that was interesting. But also, we have to remember too, sometimes I'd wake up with a glucose of 110. I'd go to bed and it'd be like 90 or 100. I'd wake up with 110, and sometimes, in this health influence society where we talk about keto diets and stuff and high glucose, people would say that you're diabetic if you wake up with a glucose of 110. And that's another reason I don't like CGMs, because it doesn't tell the whole picture.
Yeah, it absolutely doesn't. And, the 110 on a CGM, if you did a finger prick, you might have been 98. That's happened to me. So you might have been 85. I had once on the CGM, we had some Thai food for one of our staff's birthday, and my blood sugar spiked to 210, and I did a finger prick. I freaked out. I did a finger prick. It was like 132. So it does. A lot of things can have a big influence. They're not the most accurate. And, if you slept poorly the night before, that could have caused a little bit of a spike as well. But the newer ones so I got a lot less of that with Freestyle Libre, the latest one. It's called the Plus. So
that's good to know.
That one was more accurate. So they are advancing that more and more. And I've heard the over-the-counter Lingo and Stello are also more accurate now.
Awesome. So, Dr. Shafipour, as we wrap this podcast up, what do you have a passion for?
My passion is I treat everyone like my family members. So all the patients I treat like if this was my sister or my child or my parent, is for us to take care of our health, try to use diet, try to use habits. I'm a huge advocate of meditation and mindfulness. I meditate. If I don't meditate daily, I will be more stressed. Exercise, I'm a huge fan of. I run marathons. I do a lot of running, cycling, interval training, HIIT training, things like that, basketball. So for people to enjoy their life and also not just jump at drugs, especially right now, we see, a lot of patients are asking for GLP-1s, and they're fantastic drugs. They're magical drugs for weight loss, but we're seeing sarcopenia. We're seeing people losing muscle. We're seeing, these faces that are dropping. It's called Ozempic face. So to not just think drugs are the way to go, drugs or supplements. You have to look at the whole picture, try to work on the mental health. The world is always, stress is high no matter what your beliefs are. So try to work on yourself, meditate, try to take some time off from social media, from internet, just to be in the present moment. Try to work on the sleep. Sleep is a big factor in weight loss. We know if we don't sleep well, we're average 300 to 500 calories positive the following day. So sleeping well, try to go to bed early, try not to drink too late. So we're getting enough deep sleeps. That's important. And then diet, more Mediterranean diet is what we know. When every study, if you're eating more colorful vegetables, more healthy sources of protein, and eating mindfully is important. And again, I'm a big advocate of doing some type of a fasting as a part of the diet. And I think it's not for everyone, but doing time restriction benefits everyone, and it helps with kind of modifying a lot of these hunger hormones, especially ghrelin. So knowledge is important, and being proactive against your health. And then, as doctors, then we can manage, manage your hormones, manage the thyroid. And then if we need to address them with drugs, we can, but you leave drugs for last, and don't think that, I'm overweight, let me address that with a drug. I have fatty liver, let me address that with the drug. Because a lot of people, unfortunately, seek that. And I feel like on social media, we get both extremes. We get the extremes that are healthy, advocating for health, and then the other ones that are advocating for other things. So we have to filter everything and try to get the legitimate information out.
Absolutely. Agree 100%. So we're going to stream your website here. Tell us what the best way to get a hold of you if anybody has any questions.
Yeah, so my website, Shafipour.com. I also post videos on YouTube, TikTok, Instagram. It's at Dr. Pouya, at Dr. Pouya. So I post some information. If I do a fast, sometimes I blog the fast. I put a lot of information, again, about GLP-1s and what type of diet to be on. Make sure you're exercising, make sure you're eating enough protein on it too. So we're losing weight, and then we're maintaining the weight, because weight maintenance and sustaining the weight is sometimes more challenging than weight loss.
Well, thank you so much, Dr. Pouya. You've helped us realize our goal, which is to educate and empower individuals to take charge of their own health.
Absolutely.
So thank you so much.
And thank you so much for having me. I watched your other podcasts. They're fantastic. And thank you for spreading health.
And listeners and viewers, thank you for tuning in to Health Solutions with Shawn and Janet Needham. Tune in Wednesday to our midweek podcast, 8 a.m. to 9 a.m. Pacific Standard Time. Thank you.